Good afternoon, everyone. Thank you for joining us for the fourth seminar in our Fall 2025 CGNE seminar series. My name is Jenny Rank, and I'm the CGNE Education Program Specialist and serving as the facilitator of the seminar today as Janice is feeling a little bit under the weather. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care PA. Today's seminar, Aging Successfully in Place, Leveraging Person-Environment Fit to Improve Well-Being, will be presented by Dr. Christopher Struckmeyer, Assistant Teaching Professor at the Department of Human Development and Family Studies within the College of Health and Human Development here at Penn State. Before we begin, we have some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Participants with a valid RN license that attend the entire activity and complete the post-event evaluation within 1 week can earn 1 contact hour. Partial contact hours are not awarded. Certificates will be emailed to RN participants within 1 month following the seminar. As a reminder, the seminar is being recorded, and questions will be addressed during the Q&A discussion portion of the seminar in the following 2 ways. You can either enter your question into the chat, or you can use the raise hand feature and we can unmute you to ask your question aloud. The post-event evaluation link will show in your browser when the webinar concludes and will be emailed to you 24 hours after the seminar. While this is required for RNs seeking contact hours, we ask that all attendees complete to assist with data collection. And if you have any questions, please feel free to reach out to cgne@psu.edu. Next, I would like to introduce Habiba Al-Manaji, CGNE Graduate Student Affiliate and second-year PhD student. Her research interest is around factors influencing primary healthcare utilization among older adults, and she's also been a primary health adult gerontology nurse practitioner since 2017. We're thrilled to have your involvement with our center, and thanks for introducing our speaker today, Habiba.
Thank you, Jenny. I am delighted to introduce today's seminar speaker, Dr. Christopher Struckmeyer. Dr. Christopher Struckmeyer is an assistant teaching professor at Penn State University. During his time in academia, he has spent considerable time educating both college students and the general public about various topics related to adult development and aging. This work has culminated into an adult development textbook entitled Aging, Demystifying Growing Old. Most recently, he has joined Penn State University Center for Healthy Aging to help coordinate their age-friendly university initiative, which seeks to leverage older adults' experiences and expertise throughout the instructional process. Please join me in welcoming Dr. Struckmeyer. Dr. Struckmeyer, the floor is yours.
Thank you, Habiba, for that wonderful introduction. Thank you all for joining us, and thank you to Jenny and Janice for all of your help in getting this put together and the invitation to speak. So let me go ahead and get us started. So this topic is something that a lot of people wonder about when it comes to, aging in place. My parents are, in their late 60s, mid to late 60s. And I had this conversation with them frequently. And, as the adult child, they don't really want to listen to what I have to say about it. But it brings back the conversation of what exactly do we mean by aging in place and how can we make that possible? How can it work successfully? And so for this conversation, I want to first start by understanding where the gaps are in the person environment fit process. And why is it that when we don't have what we know as congruence, why does it put people at a higher risk for hospitalization, possibly readmissions to the hospital? We also want to talk a little bit about theory as a teacher, as a scholar. I always want to bring us back to some sort of framework to help explain how this process works, but also I'll explain how we tie that into home and community-based services and the larger, the greater picture in general. And then last, I always want to leave people with ways in which they can strengthen their own capacity to guide those that they work with, whether you are in a hospital setting or out in the community. So when we talk about aging in place, what exactly does it mean? Now, obviously that, aging in place in of itself does kind of link itself to what exactly we're talking about. So when we talk about aging in place, we tend to think of it as some sort of, possible government policy, but it actually is just a social policy that governments and people really want to stick by. And so we founded this policy based on all of the attitudes that people have. People want to age in their homes. They don't want to move outside of them, the memories of which they had of their children possibly in that space, or of their grandchildren, the anniversary dinners and all of the parties that they've had. People want to stay where they have control and they have those connections. But it's also a popular social policy because the government loves them, because keeping someone at home actually is about a third of the cost of an individual in a long-term care facility. And so it is a great idea in theory. Staying at home, staying where you want to be, and you have that control is great. But it's not always possible. And this tends to be the assumption that we have when it comes to aging in place. The assumption is that aging in place is always possible and home is the best option. But we know that it's not always the best option, particularly around factors like home accessibility and the external environment. Okay, so aging in place obviously is going to start in the home. And in most cases throughout, someone's lifespan, they're able to age in that space. But when we start moving towards the end of life or later in life, then home accessibility becomes a much greater conversation. And so there's some research that was done in 2015 that looked at, at that time, that there are about 25 million households in the United States where individuals were 65 years or older. And of that, they estimated that 44% of those houses needed at least, some sort of accessibility feature. Now, interestingly, though, when they were looking deeper into some of this data and they were asking individuals questions about accessibility and aging in place, they were finding that of these individuals who, were talking about their homes, 30%, 36% said having an accessible home to someone with either special needs or aging in place was highly important. 25% said that their home was accessible and appropriate to age in. But the thing that really kind of struck me was that another 25% of people said their home was not accessible, but was a great place to age in place. And so when we look at this, we see that individuals are not connecting aging in place and the need for changes and the declines in functional limitations that occur. They don't link that to the accessibility needs that they might have later on down the line. And so even with the home piece, even if you do have a home that is entirely accessible, the one thing that we also tend to overlook is the external environment. When we talk about, homes, they're built within systems. That we have a house that is built in, as part of a community, a neighborhood, which could be a part of a bigger community, and so on and so forth. But this becomes a little bit complicated because neighborhoods, one, do age. And the one thing I always send my students out and I would talk to them about is, I tell them to leave downtown State College. Everything in downtown State College, there are sidewalks, things are a little bit more accessible. But if you move out into the neighborhoods beyond downtown, we have sidewalks that are not as wide as they need to be. They might be broken because of trees or age or anything like that. Getting in and out of someone's home could be complicated because of stairs. And so the external environment also ages and could become hostile. And everything that I just mentioned is not even really applicable to rural areas. I grew up in rural Arkansas. There is nothing around. And so this is one of my own concerns as my parents get older, that they worked on building a new house that was a little bit more aging friendly, but there is no external environment that might be as accessible to them. And so when we think about these external environments, we're also tending to leave out what are called third places. And third places are spaces out in the world that are not home or work, but places like libraries or parks or cafes, but these places in which people continue to socialize and that are highly important for individuals to continue aging, because we know that remaining integrated is highly important. And so when we talk about person-environment fit, we're talking about what we know as congruence, okay? And so we see this all the time, that we continue to adapt to and alter our environment as we need to throughout the aging process. And this is what we know as human adaptation, okay? And so when we're talking about aging, we are continually adapting to the normative aging changes that we experience. Changes in our muscle tone through issues possibly like sarcopenia, or sensory changes with vision and hearing and things like that. But we also have additional changes that happen, such as substantial hearing loss or balance issues, things like that. We have the external environmental changes, some that I mentioned, the sidewalk breaking or not being, possibly, having more stairs than actual ramps. All of these things can come into play. And so as these two age, there is this interaction between the two of them, and then it can create this incongruence between the person and their environment. Now, in most cases, we're able to function, we turn a corner and there are stairs instead of a ramp. And for most of us, that's okay. We're able to adapt to that. Or stepping over a piece of sidewalk that used to be fixed but was broken. But it isn't until late life that we become sensitive to this process. Now, one of the best examples that I always give my students about this is that, we learn more about this process earlier in life when we have some sort of injury. As I walk across campus, I see students who possibly have had, their foot is in a boot. And so they have like one of those scooters, the little, scooters that they can put their knee on and walk, students on crutches. And so thinking about how, they think through this process and how that impacts their own aging process and how that might impact their own environment. So one other example that I always have is that we think about this as something occurring late in life, but there was an individual that I knew that had back surgery, but they didn't have a full bathroom on their ground floor. And so, getting up and down the stairs after their back surgery was going to be a very tedious process. And so they decided that the doctor also recommended that they stay on the ground floor. And so they pretty much slept on their couch, or they brought in some sort of bed for them. But then it was, once a week they went up the stairs to bathe in the bathroom. And so we see how this process is highly important. So talking about people's behavior and how they function in an environment is explained through what we know as the competence environmental press model. So when we talk about this, we talk about someone's abilities. What are they able to do? Okay, abilities could tie into, their psychological, ego development. Do they see things more optimistically than not? What are their cognitive abilities, physical abilities? Are they able to actually, can they go up and down stairs easily? Can they walk long distances? Things like that. And so at any point in time, our competence is going to vary between a minimum and a maximum. Some days we don't feel like we want to do anything, and other days we feel like we can conquer the world. And so our competence is always going to wax and wane depending on the day, depending on how we feel, etc. Now, the other piece of this puzzle is also what we know as environmental press, or the functional requirements of our environment. Now, environmental press are things like the physical aspects of everything. So for me, I'm looking in my office and I have 2 chairs, a table. So for me, it's navigating around these different things, taking the stairs or an elevator. For me, also, I teach in all of these different buildings, so I have to walk up a hill. So thinking about what is required in our environment, and then also the social aspect of this too refers to those expectations, the norms, and the roles that people or society demands from us. Okay, so for example, there could be, an adult child who's expecting their parent to attend a family function or to, maintain their own home. Now, while we're younger, that's fine, but what happens if, when we're talking from a competence standpoint, the individual is losing their hearing and they're unable, they're not able to process the information as well. There's a lot of voices going on. So they're not able to track the conversation like they used to. And so thinking about this, original thought processes were that someone's behavior, their ability to function in an environment, was just them and their environment. What were they able to do and what was required? But in the 1970s, Lott and Niemow, the ones who proposed this model, came forward and said, no, there's another term, because someone could have the capability of functioning in an environment. We have the needs of the environment, but depending on how the subjective evaluation of their abilities in that environment could impact their behavior. So going back to the example of the individual with, moderate hearing loss, they have the ability to hear, but they're struggling with keeping up with the conversations. Everyone, everything is too loud. Everything is getting garbled together. So, and then within that functional environment is that they're, family dinner, a lot of children, a lot of people talking. So if the individual has the limited capabilities, that environment, and then they themselves feel that this is not something that they can handle, then their behavior might be to remain home and thus possibly remaining more isolated, not being as engaging. And we know that that leads to further cognitive issues, health issues, etc. And so I say graphically because this is kind of what we're looking at. We have here on the bottom, we have environmental press ranging from weak to strong, and then from low to high competence. This diagonal line, this adaptation level, is where we want people to be. In essence, this is the amount of press that someone has and how much competence they have to meet that press. So this is where we're kind of hoping people to be. But in some instances, particularly when it comes to environmental press, we find ourselves in this area where we have too much press and not as much competence. And so this is where we begin to have those social isolation pieces. This is where we begin to feel that there's depression, there's anxiety, could be maladaptive behavior, such as, not leaving the home, things like that. And so these are things that we have to kind of keep in mind. And so what we know is that in order to successfully age in place, we need this congruence. We need this connection between the person and the environment. And so we can achieve this 2 ways. One is that we can lower environmental press. To lower environmental press, that means modifying the environment. We do this already through the Americans with Disabilities Act, but it's not always the best. Particularly when it comes to, older buildings, when the ADA was passed, I believe in 1994, people modified buildings if that's possible, but especially on campus, because this is one place I tend to live all the time, you have buildings where the ADA accessible entrance is on the other side of the building. And so if an individual can't walk very far, how does that work with their ADA accessible entrance on the other side? And so we can make some home modifications. We can widen doorways. We can install grab bars. So we can lower the environmental press as much as possible. But that's not always the case. That's not always what we can do. And so one other option is to raise someone's competence. And this is the most likely option. This is the one that works the best. So for example, in the image, we have an individual with a cane. So instead of, because there's no way that we can modify the home to help them walk better. We can add a lot of grab bars around the house, but that's not always feasible. And so we can do this by raising their own competence. Now, I'm sure some of you are like, okay, but what does this have to do with me? And so the reason that we want to talk about person environment fit is that we have a high hospital readmission rates. The latest number that I could find that was actually more than just a basic statistic was in 2018, we had 3.8 million readmissions to the hospital. And there are a large amount of reasons why that is. Some of it could be systemic issues related to the illness. It could be that the disease has progressed beyond what the individual was able to handle, and thus they had to return. Others are that it was difficult, they had difficulty adhering to their discharge plan. And then when they were assessing this data, they were looking at when, of those who came back, there was a high number of individuals that they felt, there was a review of 34 studies that looked at readmissions, and they found that of the 34 studies, 27% of the individuals across these studies were deemed potentially preventable, okay? And looking further at 1,000 patients that were readmitted within 30 days, okay, 27% were also considered potentially preventable, and because 50% with those, 50% of them felt that their readmission could have been prevented. So looking at to why, okay, they were trying to understand some of this. And some of it is, there are a lot of factors. They're tied to the hospital, tied to the individual. And so tied to this conversation is it could be that there is an inadequate post-discharge care, that the plans that that they were given were not adequate. They didn't do the things that they needed to do as well. They didn't follow the guidelines, etc. Or it could be that the person lacked the the necessary education in order to either do the wound care or do the things that they needed to do, doing their, making sure that, maybe they need to modify some of their exercises to work at home. So there is some of this. Now, because of the high readmission rates, the Centers for Medicare and Medicaid have been working on, since I believe 2013 was they launched their hospital readmission reduction program. And so they've been trying to find ways in which to do this. And part of that, or at least tied into that to help with that, has been the Caregiving Advise, Record, and Enable Act. Now, the purpose of this act across, as you can see on the map, the number of states that it has gone into effect, the whole point was that we are trying to increase or tackle the patient education. A lot of the times what we've been finding when it comes to, family caregiving issues, hospital readmissions, because people just don't know. We're not all educated in every single topic that we have. And so the Caregiver Act was designed to provide this education. And so what this act mandates is that upon admission to the hospital, the patient can nominate a caregiver. They don't have to, but they can. They're given the opportunity. They're supposed to. And then from that caregiver is supposed to be kept up to date regarding the patient. They are supposed to be informed of when the patient is going to be discharged. And then caregiver is there. They're given the discharge plan. And if the caregiver has any sort of questions about the treatment plan, then they are supposed to receive some sort of education on that plan before discharge. And I believe the legislation mentioned it's to the level in which the caregiver does understand. It's not just we sit them through one little training and they go. It's that the caregiver can continue to ask questions until they feel comfortable doing this, okay? But for anyone who's dealt with any sort of issues, family issues, etc., and if we're looking at person environment fit, we know that people need more information beyond just what is in their discharge plan. Looking at how much sorry, I lost my train of thought. I gave 2 lectures this morning. Um, you know, looking at, okay, this is what I need to do, but what if this happens? Or how do I manage this? Or can I have, can I eat citrus with this medication? And so looking at what are some of the types of information that people need. And so how this ties again back into you is that when we're looking at a lot of data, people still need help. And so looking at mainly caregivers as they see they're the easiest population to access, in the National Alliance on Caregiving and the American Association of Retired Persons released their Caregiving in 2025 report back in July. And they estimate that there are about 59 million caregivers in the US. Now, there's a lot of information in the report. I believe it's about 140 pages. But one of the important things that I pulled out was that, or that I noticed, was that they asked individuals about where are they getting their information when they need training, when they, how, if you have a question, where do you get it from? And the main sources of information were that, the caregivers, 28% of them reported that they asked nurses. Nurses were the first people who gave them that information. 18% said a social worker, and then 35% said other healthcare professionals. And this trend actually does kind of continue, that we've seen in other aspects of where individuals are asking questions of their healthcare providers or of individuals. They're looking towards those that, that they can trust, that their healthcare professionals do provide them with a lot of information, but also they turn towards those that they know. So, they turn to another family member, they turn to other people, community members. How can we, they need this information. And so when we think about how we leverage PE Fit, this does become a little complicated because everyone has their own needs. And so we see from this continuum that everyone has their own needs. And so the continuum of care is something that we kind of focus on, at least from a theoretical basis, but this is also how information and services are provided in our own healthcare system today. And so we see that earlier in time, the individual doesn't need a lot of outside sources. But as their needs increase, then they seek out more help. So it could be that they turn to family members first or friends. And then as their needs continue to increase, then they might need some community-based services, and then more formal supports might be needed, or even more skilled intensive care, so long-term care, anything like that. And so where we fit in is right here in that middle, is that families are turning to us, individuals are turning to us. And so this is where we can provide the information that they need, okay? Now, home and community-based services for a long time were not entirely around. It really wasn't until 1964 with the Older Americans Act that we actually really kind of began to focus on community-based services. And so the Older Americans Act actually created a whole federal structure. It first created what we know as the Administration on Aging, though in 2012, it was combined with the Association on Disabilities. And so now we have the Administration for Community Living. But this program does, it takes federal funds, it gives them to state programs, and then also develops overarching goals for the aging network. So the state government, the federal government's, goals for older populations, then the states provide their own, and on down. But it also then instituted that states had to have their own units on aging. And so the state levels do oversee their own state programs. So in Pennsylvania, we have the Department of Aging. I did my graduate work at Oklahoma State. I believe we were, it was a state unit on aging. Other institutions, still kind of called the Department of Aging. You might find them in Human Services. But even at a local level, we also created what we know as area agencies on aging. And so these are regional offices that support local needs. These are a great service because they tend to know every sort of home and community-based service in their area. In Pennsylvania, we have 52 that serve 67 counties. Every state is going to be different based on the number of counties, the number of people that we have. But from that, though, the main part with the Older Americans Act is that part of the 7 titles, Title 3, is what we consider the meat of the OAA. And it created a lot of these home and community-based services, okay? And so depending on the time period that we're in, these types of services have varied, especially because of the changes in all of the different consumers. So within community-based services from the OAA, there is funding for things like meal programs, so congregate meal sites, or for Meals on Wheels. It helps fund senior centers and create senior centers. We have adult day programs, family caregiver programs, information and referral services, such like the elder care locator link. All of that is built into or is helped funded through the OAA. Okay, and so the reason I bring this up is that it does provide access for these services, that these services are actually out there. Okay. And so tying back to us, though, is what can we do to promote PE Fit? And so as individuals working in a variety of different settings, whether that's a hospital, whether that's a home and community-based service yourself, or for me, it's academia. I did a lot of public presentations. One of the first things that we can do is to familiarize ourselves with the local services or the resources that we have that are around. As I mentioned, a lot of people ask those that they know of, where, do you know what service I can use for, I need someone to come in every so often to help me with home maintenance. Do you know a service that does that? Where can I find these services? The one thing that we always talk about is that when it comes to services, there's a needs-use paradox, that we have people who constantly need these services, but they are tragically underutilized for the fact that people either don't know they exist, can't get access to them, can't afford the services, and those. So there are a lot of different reasons. And the one thing that I always have students ask me is, well, we live in the age of Google and database searches. Why is it so hard? And I always turn around and I ask them this question, and I say, okay, well, if you had a functional limitation that did not, that you needed someone to come in and help you change, like say you need wound care, what keywords would you use in your database search to do that? And they sit there and they kind of think about it. And so, asking them these questions and thinking through some of these things. And even then, even if you have the perfect keywords for a database search, when you put in those keywords, you might get results back that are like Sunnyside Acres. And you're go, okay, I don't need a retirement home. I need this. But someone could have created, a company with that name that provides the services that you need that are not what you think they are. And so there are a lot of misconceptions. One other thing is to connect with your local area agency on aging and other aging offices. Having that connection is great because you can reach out to them if you have questions. You can help with if you have someone, you can do referrals. One great example that we have for those of you who might be in Center County, the aging office that we have, the local aging office that we have that put together this aging resources in Center County. This you can find on their website. I believe they also have green books that are around the county in different places that you're able to take with you. They update them quite frequently. But these are great resources to have, and that way you can call on them if you have questions. If they, if something new is added, they, reach out with you, etc. We can compile resources or resource sheets. The one thing that I always have to remind myself is not to reinvent the wheel. The National Institute on Aging, the National Institute of Health, the Administration for Community Living, the Centers for Medicare and Medicaid Services, Elder Care Locator, all of these institutions have resources, fact sheets, anything and everything that you can think of, they probably have. And so this might be a good place to put some of these resources together, especially if you are the individual who at your company who is, or your organization that is in charge of education, or you know the person who does the education, these are great places to kind of compile some of these resources. And then last is something that I know a lot of you do, but ask questions. Frequently, as we mentioned, is that people are not sure of what they need to know or even where to start. And as the professionals, we tend to have an in with what information is out there, what are some places in which we can start pointing them in the right direction. And so, walking someone through a discharge plan or talking to them about everything that's going on in their lives could help us understand that there is a bigger issue going on. And that is something that we could possibly tackle or at least point them in the right direction. And one last thing, and something that is beyond, greater for everybody, is the reconceptualization of what we mean by aging in place. Talking about aging in place, we tend to focus on aging in place as an outcome or a goal. But aging is a process, and aging in our own spaces is a process. And so age is this change over time. And so we are constantly aging in our own places. And so thinking about aging in place as more of an optimization strategy can be very, very beneficial because we can retain control over a lot of different aspects of our life that we can always come back and say, okay, there might be modifications that need to be, but I don't have to wait until late life to start this process. I can come in and say, okay, what are the changes that need to be made? What are the things that I can do? How can I optimize my own aging process now in order to maintain my independence and where I'm at right now? Okay. And so thinking about aging in place and our own PE fit, we want to always come back to the fact that we as providers can create that, we can help close that gap by raising people's competence and their congruence. Okay, thank you.
Great. Thank you so much, Chris. That was really great. If attendees want to start putting questions into the chat, I will be monitoring kind of the chat, and if anybody wants to raise their hand, we can unmute you. I guess I will start with just a quick question for you. So as I'm an occupational therapist by background, so this kind of hits home in terms of what I've seen when I go do home evaluations with individuals. They want to stay in their home, but the home isn't kind of congruent to their needs. I guess I'm just curious, have you seen, are there any like specific high impact occupations like med management or meal prep or toileting that where you're consistently kind of seeing that mismatch in like the person environmental fit that's contributing more significantly to that high rate of rehospitalization?
I guess really a lot of it comes down to what exactly is are we looking at, is it problems with the discharge plan? Is it that they didn't have all the information with the discharge plan, or was it, they just didn't follow it? And so I think for me, there's not something that I'm seeing more often, but I would think probably what's going on is that the home just isn't congruent, period. And so we have individuals who are, there's actually a phrase now called stuck in place, that there are individuals who are aging in their homes, but they have no other option, that they don't have the financial resources to modify their home. They can't install grab bars. They can't install, they can't, changing knob door handles to lever doorknobs. So there are a lot of different things that people are kind of just stuck in their homes. And that, to me, I feel like does help accelerate some of that, is that their homes in general are just not great spaces. A great example is I love to go on Zillow and look at a lot of these houses. And so, the houses that are like the 1920s, 1930s, they've all been remodeled. But now it's the people, like the houses built in the 1960s, 1970s that you're like, this is not safe. And so I think that helps contribute to the readmission rate as well.
Thank you. Hi, I'm Diane Barish. Sorry I was joining a little bit late, but I'm also going to just help facilitate the questions and answers section here. So I saw in the chat, we had a comment from Diane Moscal, and I also had one, as Jenny is like a PT, OT from her background, so that really interests her. I'm also really interested in policy, kind of the policy side of things. So you had mentioned like the Older Americans Act and American ACL and Health and Human Services. And so with all the kind of upheaval and reorganization that has been recently going on there, what do you kind of see as the outlook, for the next 2, 3, 4 years as far as that program continuing and maybe the different shape or format? If you have any thoughts on that, and if you want to share. I know that's a large topic.
Let me see if I can tiptoe around this one a little bit. So I mean, interestingly enough, the current administration, for everything else that's going on, because I know, Diane, that you're also at Penn State, that so that we're constantly, like right now, we have to do, everything is accessibility. So everything has to be accessible in our resources. So I don't know if the programs are really going to shift that much. And I'm sorry, I don't even know who the administrator for the ACL is. But under the last administration, the person who was the administrator was actually the Oklahoma State Aging Director, and he was phenomenal. So I think that there are a lot of, I would honestly say that I don't know enough to really comment heavily, but I do feel like I think it might remain the status quo on a lot of these programs. Yeah.
Thank you. I know that's like a really complex question. Answers are cloudy, as to the I'm sure right now.
And it's one of those things that I can give you an answer, and then tomorrow something comes out and it's completely changed.
So. Exactly. All right, thank you. And we also had a question from one of our graduate students here at the College of Nursing, Solomon Tangbor. He said, "Thank you for enlightening me on some aging resources available in Pennsylvania. I am curious to know if all these numerous institutions coordinate their services in a way that the public is aware of and can easily access." So I guess kind of going back to the caregiver part of it as well, if you have someone who's trying to help you coordinate your care potentially after an acute care hospitalization, like, is there a way to sort of case manage and, all the services?
Some places do have case management. However, in my knowledge, it's usually left up to the caregiver themselves to manage everything. But there has been a movement in the last, I would say, decade, where the state, at least the state governments, are on to the fact that, there's a lot of intersectionality, that if you're having a problem here, you're probably going to have a problem over there. And so they, they're starting some of them call them like no wrong door policies or a one door policy. But the whole point is that you have one number that you call no matter what you need. And so you can explain your problem, and then they say, okay, I can help you with this. And then we're going, once we're done, we're going to refer you over to this agency, and then they can help you with that. And so it's still left up to the individual to do it themselves, to manage kind of how everything is coordinated. Now, I think some hospitals do have some case management to help coordinate some services, but in most cases, it's still up to the individual. But a lot of agencies are still trying to make it better. Like Bellefonte just opened, their renovated county organization department, and they put all of human services in one building. And they're all supposed to be kind of next to each other. That way, if you need aging services, you can go there, and then you need child services, you can just go right next door. So they're trying to put everything in one place to at least make it easier. Yeah.
Yeah, that a lot of times it's going back and forth over all the different locations that can be really challenging as well. Yeah.
Mm-hmm.
We do have a couple hands raised. So we'll start with George Panzak. George, if you would like to unmute.
Yes, thank you for a very nice presentation. George Panzak, I'm a DNP student at the College of Nursing. I'm curious, are you aware of any programs or guidance for the aging population to initiate or improve their physical fitness in their environment?
Do you mean, I guess, could you clarify what you mean by, what do you mean by a program? Is it like a policy out there?
Not per se, just programs or resources for the aging population to initiate, engage, or improve their physical fitness qualities.
Yes. So there are, yeah, thank you, Diane, for throwing out there. There are groups out there that provide information. If there's something specific that you're looking for, there are strength training resources, like crazy, probably through the NIH or the NIA. That there are things like chair yoga. There is one thing that I growing up in Oklahoma, when I was studying in Oklahoma, we would talk about that. We would go out to the public and tell them, if you don't want to go to the gym, go in your kitchen and find the largest can of canned goods you have, and you can use that as strength training. Growing up in Arkansas, my mother had a lot of cast iron skillets, so I tell her to go pick those up. And so you can use stuff around your house. So there are a lot of resources out there just for different ways that you can do strength training, even without having to go to a gym. Mm-hmm.
Thank you.
Yep.
I think we have Sarah Songer with her hand raised as well. So, Sarah, if you want to unmute and ask your question.
Okay, two things. One, you talked about there's going to be a big push for exercise programs, because I just was seeing they've made the connection between that and Alzheimer's. The markers for Alzheimer's, that just came out, yesterday? Yeah, those markers just came out. So there's going to be a big push for that. But the other comment that I wanted to make was, you talked about Belfont, but area agency on aging, and I'm part of that aging in place kind of thing. But area agency on aging, when it first started, was coordinating all of that, so they could get you to home care that was appropriate for your needs. In other words, did they have people who could mobilize you if you needed that and whatever? But what's happened over the years is that it's changed, and people mostly see it, they go there for their taxes. So if we go back to the original part of Area Agency on Aging, that was a very good place. And because it was in the county seat here in Center County, and the equivalents other places, it was a super place. Everybody had the numbers to do that. And I was working with them to change their green book, because if you know the history of green books, you wouldn't make the Center County green book. I know it means go, but it also means where you could stay if you happen to be, yes.
And that's also a problem inherent with a lot of our system too, is that with the almighty dollar, and how much money, how much profit can be made without paying the people doing the job as much as possible. We're we like to think that this area is not an urban area. It is very rural. And it's the same issue that my own family experienced when we were taking care of my grandmother with vascular dementia. We were, the closest town with probably anything was Conway, which was 45 minutes by interstate away. we had no idea about the Alzheimer's Association or really the aging services. And I'm pretty sure if we called aging services, they would have been like, well, we've got something for you, but it's, 45, 50 miles away. And so a lot of individuals are kind of left to their own, that, even reaching out to the AAA, they, in areas like this, they might say, well, this is the best I can do. Mm-hmm.
Great. I think that was all of our hands up at this time, right?
We do have one more hand up now. Let's see. Michael, I do. Go ahead and unmute, Michael.
Okay. Good evening from Ghana. I'm a postgraduate student from Ghana. Thank you for the presentation. I'm very inspired with this presentation. I joined from Ghana because of my interest in aging and also telehealth. Mm-hmm. And I admire to be with you people at Penn State for my PhD in nursing, which I will focus in telehealth and geriatric care policy research. I've been following you, but today I joined to get more insight. My question has to do with, in the context of the 3.8 million admission in 2018, that is the readmission figure you quoted in your presentation. Mm-hmm. I understand is based in US, whereas in my country, which is Ghana, we have so many factors that is affecting or defeating the aging in place. Because mostly, I'm at the clinic, mostly people come to the facility just because we've discharged them, though they would have followed the discharge plan, but due to one or two issues in their household, they will prefer coming back to us at the facility more than staying at their home. And this highlight what you are saying. So I would like to have these plans in my country, and I would like to come and engage more insightful ideas there. Then I will come and help my country, because I'm a young researcher and I want to help my country in terms of geriatric care. Thank you for this presentation.
Thank you.
Okay, that was the last hand up, so I can go back to the chat questions. Okay. So there's a lot of thank yous and really appreciation for the talk and the information. But there were a couple of comments that were focusing in on like home modifications. Mm-hmm. So like Janice was mentioning contacting the area agency on aging as being key for like connecting with resources that can help with home modifications, and that right sizing or moving to a house that is more age friendly can be really beneficial. Diane Moscow is saying that. And I was wondering like how the concepts of like universal design, I know with an older home that may not necessarily be possible because that would be a remodel and sometimes structurally that just wouldn't be feasible. But like the more we can make new homes, universally accessible, how that can help people like age in place in the long term.
Mm-hmm. So, kind of, first of all, yes. So going back to kind of my very last slide, that is kind of where the reconceptualization of aging in place occurs. Because when we think about aging in place, we tend to think about, okay, well, when I get older, I need to change things. But if we follow the universal design aspect, that really would be beneficial for everybody, because, you might have friends who have accessibility issues that, if you have an individual, a colleague, a friend, anybody in a wheelchair, and you don't have a wheelchair accessible entrance in your house, then that individual, you're either going to have to, do a lot of things to get them in the house, or they won't come over. And so really it's kind of that notion of that if we follow the universal design aspect, then we really are creating a space that anyone can age in, and it's more aligned with the age-friendly aging in place mantra. Yeah.
Yeah, and we're sort of in the process, and unfortunately Janice isn't a little bit under the weather, so she's not able to maybe to chip in, but maybe she can put it in the chat because she's a part of the Age Friendly University. Mm-hmm. work
So
that
am
we're
I.
doing.
Yep.
Oh, good. Yes.
Yeah.
So yeah, so that hopefully with Penn State we can make the whole university a little bit more age friendly, which would only increase accessibility for everybody,
Mhm.
which is great. Let me see.
Diane, if it's okay, I'll just share a couple squeaky words here. Chris, so much of what you shared really resonated with me. I thought of countless, both personal and professional examples of so many of the uh, topics you were discussing today. One was that connection or the interrelationship between aging and people living with disabilities. And
Mhm.
that if we're doing things to improve access for people living with disabilities, that's going to improve things for people as they age as well. But I was also very intrigued by the competence environment press model.
Mhm.
Thank you for sharing that. Um, as you were describing that, you were referring to the individual and their abilities, their competence, and
Mhm.
things like that, as well as the environment. It seems to me, and you touched on this when you talked about caregivers, that caregivers could be another aspect of that model. Do you want to
Mhm.
talk about that a little bit?
So, uh, well, so technically the caregivers are a part of that, but it would be more of that. In essence, if you think about it from this perspective, the caregiver is assistive technology. That because when we think about disability in the home or people's functional limitations, what we focus on doing is trying to increase their competence. And so we do that by, helping them with any, helping their ability in increasing their abilities as much as possible. This is what I get for lecturing 3 times in one day. But so technically kind of the caregiver would be a part of that. But then also the thing is that the caregiver would have their own model as well. And so it could be that the caregiver, is having a hard time providing care because of the environmental press of that environment, but also their interaction of that too, because that's part of the social demand piece is that they feel that they have to take care of this individual and they don't want anyone else to help them, and so they're going to do it on their own, and the environment is not suitable for them either, and so it's big giant mess. Yep.
Yeah. Yeah, it's such a challenge to have that all be congruent. So thank you for sharing those different perspectives.
Mm-hmm.
All right, well, I think we're kind of winding down on our time here. So just want to thank you again, Chris, for your great presentation and your wealth of knowledge. And thank you to those for attending our seminar today. As a reminder, when the session is closed, the post-event evaluation will pop up in your browser to complete either right now or you'll receive the link 24 hours later and you can complete it then. If you're an RN seeking contact hours, you'll need to complete that within a week, and then certificates will be emailed out to you within a month. And please join us again next week. We have our last seminar of the semester next Wednesday at noon. Thank you, everybody, and thank you again, Chris.